So we're back for Unit 8, Antenatal Nursing Part 3. This unit deals with prenatal care and prenatal assessment fetal testing, which is part of what we do in prenatal care. The next part of the unit will deal with health promotion and education, how we help mom make better choices to keep her baby healthy. There are a lot of really good reasons that we encourage women to seek prenatal care, especially early on in their pregnancy. And we've already touched on some of them when we talked about fetal development and genetics. The first thing that we are looking for is risk factors. And this is one of the ways that we can help promote a healthy outcome. If we can identify risk factors early, we can look at either behaviors or medical conditions and target them for intervention to get a better outcome for mom and baby. For example, if we identify that mom is smoking, we can give her education about smoking cessation. If we identify that mom has a history of genetic disorders or that she's of advanced maternal age, or if she has psychosocial issues, maybe something's going on with her and the father of the baby, if we can identify risk factors, we can intervene and get a better outcome for, both mother and baby. The second thing we want to do is we want to get a thorough physical assessment. And this is going to include our laboratory testing. If we get ultrasound to visualize the fetus, it's going to include all of our genetic screening if we need that. And it's going to include assessments such as the fetal heart tones, mom's vital signs. We're going to look at usually the weight and the urine, and we're going to kind of track mom through the pregnancy to get a feel for how baby's developing and how mom is handling the pregnancy. Of course, if she has pre-existing conditions like diabetes or hypertension, we'll keep a closer eye on those things, and some of them might warrant more frequent fetal assessment or different types of fetal assessment. Now, the next reason that we want to encourage pregnant women to seek prenatal care is that we do a lot of extensive education with them during their pregnancies. Hopefully, if they can get some preconception care, we can do all of these things as well before the pregnancy occurs. And that sort of helps us control conditions and teach mom about folic acid and prenatal vitamin before she actually gets pregnant. And that will reduce her risks considerably. However, we don't always have that option. About 50% of pregnancies are unplanned, and out of the other 50%, a lot of moms don't really seek preconception care. It's certainly something, if you ever work in that area of health, ambulatory care, you might want to discuss preconception care at a routine GYN visit, like an annual visit. But we do a lot of education with people. Pregnancy is one of those things that tends to breed old wives' tales. And a lot of people have unanswered questions. They have misconceptions, or maybe they have risky behaviors, and we can target them for intensive education to help them have a better outcome. So the first prenatal visit is a pretty big event, and it's usually a little longer of a visit than most of the others. There are a lot of things that we do at that first prenatal visit. We get a complete health history. And that's going to include familial history, all current and past medical history for the patient. We're going to solicit some information about the dad and find out what his health history is. And we're going to find out a lot about mom's health habits. So that is one of the things we do. The other thing that we're going to do is establish the EDD, which is the expected date of delivery. And we already did that on the last video. We were talking about Nagel's rule, and we used the gestational wheel. So we're getting a little bit familiar with that. The next thing that we're going to do is classify mom's obstetrical history using the GTPAL system. And the GTPAL system is a way of discussing how many times a woman's been pregnant and how the pregnancies have ended, what the outcomes were. So let's get the terms up there. G stands for gravida. Gravida is the number of times that mom has been pregnant. Okay, let's see, we'll move over here. Oh, let's just make some room. Sorry. There. Okay, so that's the number of pregnancies. T stands for term deliveries. Okay, and a term delivery for our purposes counts as anything over 37 weeks, whether that baby is born alive or a stillbirth. The P stands for preterm. Preterm deliveries. And a preterm delivery for our purposes is anything from 20 weeks to 37 weeks, or 36 and 6/7. Once it gets to 37 weeks, it's considered term. So we have gravida, term, and preterm, and we'll do some examples so that it makes a little bit more sense. You have A, which stands for abortions. And these can be spontaneous or they can be elective abortions. But an abortion is considered any pregnancy that ends before the gestational age of 20 weeks. Okay? And then you have L, which stands for the number of living children. So people can have very, very complicated obstetric histories according to the GTPAL system. And sometimes we simplify this to GP, which is gravida para, which is just how many pregnancies, how many births. But the GTPAL system gives us better information. So let's kind of see how that might work. There are always going to be test questions, whether you're taking ATI or whether you're taking an exam, that end up having you calculate the GTPAL system, just like there's always a test question guaranteed on Nagel's rule. So GTPAL system, let's try and see. We have a woman. She is pregnant for the 5th time. So we'll make her a G5. Okay, so G5, when we go to T, let's say that she had one stillbirth at 38 weeks and one live birth at 39 weeks. That makes her a T2. So now we ask mom about her other deliveries and find out that she had a pretermer at 23 weeks who did not survive and another pretermer at 25 weeks who did. So now she is a T2, G5 T2 P2. Okay? We'll say that she has no spontaneous or elective abortions. So that is 0. She has 2 living children and the current pregnancy. So she has delivered 4 babies. She is pregnant with the 5th, and that's her gravida para. Now, just looking at her gravida para, if you know that she's had preterm deliveries, you know that she's at risk for another preterm delivery. That is the biggest risk factor. So you'll want to ask her a little bit more information about what was going on then. And you'll want to screen her for other risk factors and try to correct any health conditions that might contribute to that. When you find out that she has only 2 living children, you might want to find out how the 2 children were lost, whether that was stillbirth or infant death. But you're always going to get this history. And just knowing that she's been pregnant 5 times and only has 2 living children, you know that this is a woman who has significant risk factors. We are concerned about preterm birth, and we're also concerned about her psychosocial adaptation to pregnancy, which can be altered when there have been losses. So let's do another GTPAL history, and then we'll move on. We'll do some more in class. Okay, so let's say that we have a mom, and this is her 3rd pregnancy. So she is a gravida 3. We'll say that she has no term babies. So that is no babies at 37 weeks or beyond. She has no preterm deliveries. She has 2 elective terminations, and no living children. Okay, so that's kind of how that works. There you go. Practice doing a few of those, and we'll practice doing a few in class during case studies. Like I said, these make great test questions. They always seem to end up on a test, along with the Nagel's rule. So just kind of take a note of them. That is one of the things we do on a prenatal health assessment. Okay, so also at that first prenatal visit, we're going to give mom a pretty extensive health history questionnaire, something like that. And it's going to have a lot of the same questions that you use on a regular assessment, health assessment, like you did in physical assessment, nursing 137. But there are also certain questions we're going to ask mom that are specifically of concern during pregnancy. For example, we're going to ask her about obstetric outcomes. And this is like outside of that GTPAL system. We're going to want to know particularly, did she have any problems with her pregnancy? At what gestational age did she deliver? We're going to know how much her babies weighed. We're going to know how long her labors were. What the outcomes, did she have C-section or vaginal? Any operative deliveries? Remember, operative deliveries are your forceps and vacuum. We're going to want to know any problems with labor. Did she have a shoulder dystocia? Did she have failure to progress? Did she have anything that might impede this pregnancy? Okay, so those are some of the questions that we're going to ask. If you need to back that up or pause it now to take notes, go ahead. But I'm going to give you a form when we go back to class so that you can fill out a health history on like a case study type patient. We're also going to know about pre-existing health conditions. Moms with heart disease, moms with diabetes, moms with chronic hypertension, moms with history of spina bifida. I mean, you kind of see it all. Everybody gets pregnant, more or less. Not everybody, but a lot of women get pregnant that in the past maybe were advised not to. And so we need to know about these pre-existing health conditions. We want to know about problems like incompetent cervix. We want to know about whether or not she had ROGAM. If she was Rh negative, sorry, autocorrect strikes again. But we want to know about ROGAM. If she had a miscarriage or if she had a termination, was she given the ROGAM? Did she come back for prenatal visits and get it in a timely fashion? Now, generally speaking, and this kind of goes back to when we were talking about the placenta. The placenta is the organ of gas exchange, but blood should not mix at the level of the placenta. It should really be a place where you transfer oxygen and nutrients and get rid of wastes, but it should not be, there should not really be any fetal or maternal mixing. However, sometimes mom can have trauma or mom can have a hemorrhage or there can be something that goes wrong where she does get a little bleeding or a little blood mixing, and we don't always know that that occurs. So mom could make antibodies after that. So if she had an abortion or a miscarriage and did not get ROGAM, we would want to know about that. So that's ROGAM. We want to know what her contraceptive history was. If mom was taking oral contraceptives during the first trimester and didn't know she was pregnant, we would want to know to look for certain anomalies in the baby and certain problems with the pregnancy. We would want to know if she was using an IUD when she got pregnant, and could the device still be somewhere in utero, which would increase her chances for miscarriage and also increases her chances for ectopic pregnancy. We would want to know about abnormal pap smears. And abnormal pap smears often signify some type of cervical cancer. She may have had a LEEPS procedure or another procedure, but whenever you have a problem with the cervix, now you worry about two things. You worry about incompetent cervix, which is when the cervix dilates inappropriately, and you worry about things like cervical stenosis, when the cervix will not dilate because of scar tissue, secondary to a LEEPS procedure. So we would probably want to watch this mom with transvaginal ultrasounds to look and see what the cervical length is and whether there's funneling. And we'll talk about all that later when we talk about fetal testing. Okay, so we want to know about any GYN surgery, any uterine surgery, any history of endometriosis or infertility. We would want to know about any STDs. And STDs can be important for a few reasons. Number one, if mom has any scarring in her fallopian tubes, she could be at risk for an ectopic pregnancy, which we will talk about in a little bit. Hold on one sec. Along with the risk of ectopic pregnancy and scarring, we also look at things like HSV, herpes, which can be transmitted to the newborn. Chlamydia and gonorrhea can cause eye disease if the baby gets it through the birth canal. And chlamydia also can cause like a pneumonia. Syphilis is another STD that we worry about, and certainly HIV, because the baby can acquire those diseases through the birth canal during delivery. We'll talk about that during high-risk pregnancy. Okay, so we also want to know about exposures. Talk about contagious things. Toxoplasmosis. And toxoplasmosis is a cause of mental retardation. And it's found commonly in like cat litter and undercooked meats. So, of course, we always want to counsel mom, and we talk about health promotion and education, not to handle cat litter, because that increases her risk for toxoplasmosis, especially if she has outdoor cats, and also not to handle raw meats, which in general is a good idea anyway for food safety. And we're going to want to know about her rubella status, and we'll draw blood for that at the first prenatal visit. If mom comes to the hospital with no prenatal care, we draw it anyway, because congenital rubella, a baby acquires rubella through mom. It can cause blindness, deafness, mental retardation, cerebral palsy, and other problems, especially if it occurs at certain critical periods of development. And I have seen congenital rubella. It is pretty profound in some cases. It can be milder in others. But if mom is non-immune to rubella, this is not the time to immunize her, because the rubella vaccine is a live virus. So we don't want to give it to mom. We could actually cause her to acquire a mild case of rubella, which for her would not be an issue, but for her fetus it could certainly be. We want to know about varicella. Oh, excuse me. And varicella is good old chicken pox. Again, not devastating necessarily when you acquire it in childhood, but if you get it the congenital version where you're acquiring it from your mom, that could be also fairly devastating to the fetus. Cytomegalovirus. And this is something that goes around in preschools, CMV. And if you're not immunocompromised, it's usually no big deal. But pregnant women are considered slightly immunocompromised. Hold on, let me see if I can fix that here. There we go. I just make more room, that's all. Okay, so CMV, if you are pregnant, also causes mental retardation. Hepatitis, we want to know about that, and we will draw blood for that. At least for hepatitis B, it's sort of a routine. We test for the surface antigen. Hep C, less commonly. We can do a hep panel on people if we suspect a reason to. If mom has tattoos, we usually test for hep C. Or if she's considered at risk for any other reason, if she's an IV drug user. But certainly if you see a lot of tattoos, especially if they're sort of more of the crude variety, where equipment might not have been sterilized. So those are some of the things that we want to look at. We certainly want to look at any history of heart disease, asthma, and any pre-existing disease. We also screen mom for any mental health disorders because they can, here, let me just put that in there. Mental health. They can be exacerbated during pregnancy. And the meds for a lot of your psych disorders can be pretty bad for a fetus. There are some that are sort of more acceptable. I think Prozac for depression is one of them. But certainly the meds for bipolar disorder and schizophrenia have much more serious side effects, particularly the anticonvulsants. So we want to know about those. Okay, so we also want to know, while we're asking mom all these questions, we want to know about her risky behaviors and environmental exposures. And we've already talked about a few. We've talked about exposures to certain diseases and to viruses like toxoplasmosis and CMV. But we also want to find out about smoking, alcohol, substances. We want to find out about any medications, and that includes over-the-counter, herbal, and prescription. Now, there are a few prescription medications that are pretty common, but they can be very teratogenic. We have Accutane, which is an acne drug, and that causes horrible birth defects. We have the anticonvulsants, as I mentioned, and we also have drugs like ACE inhibitors. So let's talk about the anticonvulsants. Can cause cleft lip and palate in particular. Then we have ACE inhibitors. Let me put them somewhere. ACE inhibitors are a class of antihypertensives. And they can cause birth defects as well. I said Accutane. That's something that shows up on standardized testing a lot too. I don't think it's going to be on any of my exams, but it's something that you might see again. So prescription medications could be important as well. Certain antibiotics like tetracycline stain the teeth. But those are some things that you should be aware of when you're taking a history from a patient. Okay, so after you get a health history, you're going to do, let me shrink this a little bit because I don't really need it. I'll put it up top. Okay, after you do that health history and that questionnaire, and you've classified mom's pregnancy and figured out her due date, you're going to do a physical exam. It's going to be a pretty thorough head-to-toe exam, but it's also going to include a pelvic exam and a pap smear. Okay, in the pelvic exam, we look for a few things. We look for any lesions or whatever that might suggest mom has a sexually transmitted disease or some other problem. But we're also looking for those signs of pregnancy. This is where you're going to see your Chadwick sign, your Hager sign, your Goodell sign. So that's one of the things that we'll see. They're also looking for the size and shape of the pelvis. Okay, and one of the measurements they take, probably the most important one, and it's really sort of almost a subjective thing. They measure with their fingers while they're doing the exam the, diagonal conjugate. And hold on one sec, I'm going to see if I can find a picture that shows you what that is. Okay, so here's a picture of an examiner using a model pelvis to show you how to get the diagonal conjugate. And you can see they're going from the, here, let me get a little pen and mark it, the sacral prominence to the arch of the symphysis pubis. And the expected measurement for that is going to be about 12.5 centimeters. That's what's considered an adequate pelvis for giving birth. Truthfully, although that's an important measurement and it's certainly something that you should know about, It's hard to tell whether a pelvis is going to be adequate for any given baby until you give it a try. Sometimes an examiner can really feel that tight pelvis. There are different shapes of pelvis. We have, you know what, let me just make some space here. Let me get rid of that. Make it smaller and kind of make it disappear a little bit. Okay, so the different shapes of the pelvis. And without x-ray, it is sometimes maybe a little bit difficult to determine this just from physical exam, but an experienced examiner can usually feel it. You have the gynecoid pelvis, which means that's like the Greek derivative for female-shaped pelvis, a gynecoid pelvis. This is considered the most adequate pelvis for giving birth. Let me see if I can find a picture of that for you. Okay, so here's a picture of all the different pelvic types. And there's the gynecoid pelvis here. That is considered the most favorable for giving birth. You can see that it has a nice wide pelvic inlet so that the diameter of the head can easily pass through. And that is the most common type of female pelvis. We also have an android pelvis, which means male-shaped. And you can see from that picture, that looks a lot less favorable for birth, because look at how narrow those arches are and, you know, how difficult that's going to be to pass. Now, it's impossible to say whether every android pelvis is unfavorable for birth. There are a few cases if you have a small baby and you know, mom's pelvis is wide enough that even though the shape is irregular, you may get a protracted labor, but you may have a vaginal delivery. The platypoid pelvis, here, let's move that out of the way here. Platypeloid, and that was an interesting interpretation. Platypeloid pelvis, this is really a no-go. The diameters are just too squished. It's not going to allow a baby through. And then an anthropoid pelvis. And this one can be favorable for giving birth as well. Most women have a pelvis that's adequate for giving birth. Most of them will fall either into the gynecoid category or the anthropoid. Let me point that one out to you. And you can see that they have good diameters. One thing that I always point out to students is that there's like a misconception that if a woman has wide hips, looking at her from the outside, that she's got an adequate pelvis, and that's not necessarily true. We're really looking at the internal structure and not the external structure. There we go. Hold on, get rid of some of the stuff. We can get rid of all of it, as a matter of fact. But that's some of the things that they feel for on the first prenatal visit. Also on that first visit, we're going to do a lot of laboratory evaluation. And I'm going to call your attention to this because this is where we pick up a lot of our risk factors. So, what are some of the tests we run? Well, we do a blood type and screen. And along with an RH factor. Okay, so that's important. We usually do a complete blood count. And that's going to give us a pretty good indicator of mom's iron status. We want to look at her platelets. And remember what I said, her red blood cells go up, but they don't go up as much as her plasma volume. So she might look like she has a decreased H&H, but it's still not going to dip too low. We want to know what her H&H is. If it drops really below 11, we're probably going to start supplementing her and talking to her about her diet. And you already know from hematology what dietary types of factors we're going to recommend. Okay, so your H&H, your red blood cell count, you're going to look at platelets. When platelets drop below 150, we start to get worried. When they drop below 100, we start to get a little bit more worried because mom's at risk. We do a rubella titer. We want to make sure that mom is immune. That is titer, not tiger. Sorry. We're going to check for hepatitis. I think we already kind of said we would draw that. B, definitely. C, if indicated. Let me move this up a little bit. There we go. Now, in New Jersey, we do HIV testing the first and third trimester with mom's consent. And it's unusual to have a mom who does not consent to HIV testing when you tell her it's mandatory and it's routine. And certainly we want to get that specimen if we can, because if mom is at all HIV positive, we can prevent transmission to the baby in most cases by administering antiretrovirals like AZT during labor, and also if she takes her HIV meds during pregnancy, she'll seriously reduce the risk of transmission to her infant. The higher the viral load, the more likely mom is to transmit that virus to her baby. So we do want to know that. And just incidentally, we didn't use to test for HIV when we started, and we did get some new cases during pregnancy. It was the one time that mom would get tested. And we are starting to see a lot of new cases now, and I think that has to do with the rise in IV drug abuse. But so that is an important test to have because we can prevent serious lifelong illness for that child. We're going to screen for syphilis, and screen that we normally use is the RPR, which is known as the rapid plasma reagent. Syphilis is rare, but it has severe congenital defects, and we have had a few cases of that in the last few years. The only medication, by the way, that's effective against prenatal syphilis is penicillin. And so if a mom is allergic to penicillin, I've actually seen them do this where they take the mom to ICU and desensitize her a little bit at a time. So those of you who think, I'm never going to work with pregnant women, I'm only going to work in the ICU, guess what? We get them down. You get them down there sometimes. And that was one of the indications, that in case mom went into anaphylaxis, they wanted her on ICU. And then, of course, they get the pap smear. And that detects the abnormalities like cervical cancer, and they can also see some infections. BV a lot of times will show up on the pap smear. They might see GC and chlamydia. They usually get cultures for GC and chlamydia. And that's sort of a routine thing. And the other thing that we routinely get at the first prenatal visit is an initial BMI. We want to know what mom's pre-pregnant weight is, and if she's 9 weeks and she's gained 15 pounds from what she says her pre-pregnant weight is, then we want to address, is she really eating for two? Do we need to intervene? But when we get the initial BMI, we're going to determine for that mom what her weight gain should be. If she's of normal weight, she gets one sort of recommendation, and that's usually for 25 to 35 pounds during the pregnancy. Hold on one second, I'll get that for you. So if mom is normal weight, let's write that down. She's going to get a recommendation to gain 25 to 35 pounds over the course of her pregnancy. The way this is going to be distributed, we're going to see her do between 1 to 4 pounds. Let me just break that out a little bit. In the first trimester. Okay, then she's going to gain 1 pound per week in second and third trimesters. Oh, and that's a rough guide. If mom is gaining less than that, we worry about the fetus growth and her nutritional status. And if mom is gaining more than that, we start to worry if she's putting on fluid or if she's gaining too much weight for her baby. So let's see what happens if mom has a BMI that's lower than normal. she's going to want to gain 28 to 40 pounds. And that is considered normal over the course of a pregnancy. If she is overweight, and by overweight, remember that your BMI chart way back from 131 says from 25 to 29.9 BMI. We want her to gain 15 to 25 pounds. And that gives us the best outcomes. If she is obese, and that is a BMI greater than 30, we only want her to gain 11 to 20 pounds over the next 30 so many weeks, however many weeks she is. Over 40 weeks of pregnancy, really only 11 to 20 pounds. Pregnancy is certainly not a time for weight loss for anybody, but that is data you want to collect at the first prenatal visit so that you can educate mom appropriately. So after the first prenatal visit is over, we need to keep mom coming for care. These visits are a little less eventful, but we want mom to return to the office every 4 weeks until about 28 weeks. Okay, from 29 to 36 weeks, providers usually want to see their patients every 2 weeks. And this can vary. If mom has risk factors, she's going to get a whole different set of instructions. If you are 37 plus, every week until you deliver. And again, if you have risk factors, you might be seen twice a week for a non-stress test, which we're going to talk about. We talk about fetal assessment a little bit later in this video. But so what happens at these visits, at these subsequent visits? Well, usually by the second visit, come on now, there we go, we can hear fetal heartbeat. We continue to gather data from mom. We're continuing to ask her questions. We're tracking her vital signs. We're going to check weight and blood pressure in particular. We're going to assess for fetal movement if she is at the point where we expect to see it or expect for her to experience that. And if she is more than 12 weeks. At 12 weeks, the fundus of the uterus, the top portion, rises out of the pelvis where it can be palpated. So we're going to assess fundal height. Let me get a picture of that so you can see what that looks like. Okay, so there's our picture. At 12 weeks, it's just above the symphysis pubis, that fundus. By 16 weeks, it's halfway between the umbilicus and the symphysis. By 20 weeks, it should be at the level of the belly button. And then each week thereafter should grow by about 1 centimeter. And the way that we measure this is that we take a tape measure, and I did buy some tape measures for you guys to sort of play with. You measure from the symphysis pubis to the top part of the uterus. It feels a little bit like the fundal check that you guys did in lab, but you're just going to expect it to be a little bit higher. Now here's the thing. It can be a little subjective from one examiner to the next. So don't let mom freak out if she's 32 weeks and you're only measuring a 30 or 31. Just explain to her that a centimeter is a very small amount of movement, but you do want to track and see what the trends are. If you're measuring really big and the last person before you was measuring big and, you know, maybe you've got an obese mom, you might want to follow that up with an ultrasound. That's what we call size greater than dates. Okay, so that's your, sometimes we abbreviate that to S greater than D. Ooh, that didn't go right. There we go. Okay, so sometimes you'll see that. Okay, and that's when you take that tape measure, and you can measure 32 centimeters from the symphysis pubis to the fundus, but you really expect it to be at 27 or 28. That's size greater than dates. It's worth a follow-up. And they'll usually look on ultrasound, because if you have a macrosomic baby, then you worry about not being able to deliver it vaginally. And then we have, if your fundal height is smaller than what you expect, we have size less than dates. So you'll see that sometimes on patient charts. You know, referred for sonography for S less than D, size less than dates. So if you're expecting to find the fundus at 36 centimeters above the symphysis pubis, and instead you measure it at 27, we'll just say that is size less than dates. And then we get concerned about intrauterine growth restriction. Maybe we worry whether we dated the pregnancy appropriately, but you want to assess and follow that up with an ultrasound. Now, when we talk about fetal heartbeat, and let me kind of move that. Hold on. When we talk about fetal heartbeat, we do that with a handheld Doppler. And early on in pregnancy, like I said, we kind of angle it downwards toward the symphysis pubis and kind of dig down under that pubic bone and try and find this little tiny fetal heart with a fetus that usually is trying to move as far away from that noise as possible. As the baby gets a little bit bigger and there's a little, you can find it a little bit better, you're going to try and assess for that fetal heart probably a little bit above the symphysis pubis. Say if you're 16 weeks and your fundus is between the umbilicus and the symphysis pubis, where you're going to aim a little bit lower than that fundus and a little bit higher than symphysis pubis. You look around the sides. Once the baby gets to be big enough to palpate, we'll do Leopold's maneuvers, and I'll show you that in a second. But a normal fetal heart rate, and I always try to count for a minute. If they're moving a lot, sometimes it's hard. But the FHR, which is usually how we abbreviate it, we can also abbreviate it as fetal heart tones, FHT. Normal is, according to the NICHD, which is the agency that decides stuff like that, 110 to 160 beats per minute. Okay? And that's a really fast rate to count. When we get to class, I've got an audio recording of that. And it's a shoo, 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 shoo. When you listen to mom's heart rate, you sometimes get what's called a phonic souffle, and that's what you're really hearing is mom's blood flow through the major vessels. And it's definitely a different rate. Now, you might think you're hearing a decel, but if it's real rhythmic, palpate the mom's pulse and see if that's what you have. When we have fetal monitoring, it's one of those things, and we'll get to fetal monitoring a little bit later too. A lot of times I like to put a pulse ox on mom because it'll record simultaneously on the strip what her heart rate is, and I can kind of prove that I have fetal versus maternal. But fetal heart rate check is sort of a normal part of the assessment when they return to the office. Okay, so the last thing that we're going to talk about in terms of the routine prenatal visits, aside from the education that they get, the assessment that we do, we can do something called Leopold's maneuvers, and I have a picture of it here. And we can practice it to some extent when we get back to class. Leopold's maneuvers are basically a way of palpating a woman's abdomen to find out where the fetal position is. You can also estimate fetal size from it. But you can sort of see, you start at the top. A head feels hard and bumpy, a butt feels sort of soft and squishy. The back should feel long and smooth. And then we have what we call the small parts, which are just, hands and feet, and they feel bumpy and knobby. So you can see the examiner starts at the top and then sort of palpates down the sides. One side's going to have a smooth, hard back. The other side's going to have those bumpy parts. And then they feel sort of down at the symphysis pubis. Expected finding, hopefully, if the woman is near term, is the head. And then they sort of feel the other way, and you can get a pretty good estimate of where that baby is positioned. And the reason that Leopold's is important to you as a nurse is it helps you find where to listen to the baby's heart. Okay? You want to listen where the back is. You don't want to listen where the small parts are. You don't want to listen where the head is. You're not trying to go for a chest. In fact, if that baby is OP, turned around sunny side up, as we say, where it's facing the ceiling, it's actually a little bit harder to hear because all of the extremities are going to be curled up in front of it, and the baby's going to be able to flex that trunk in places where it's harder to hear. With good equipment, you can hear things fairly well, but the easiest way to do it is to look for the back and then put your monitor right there. And when we talk about fetal monitoring, we'll kind of get some practice with it. But it's kind of a reassuring thing for mom if you don't have to like really dig around to find a fetal heart. Especially if she's coming in for something like a decreased fetal movement. I haven't felt the baby move all day. If you're, poking around, you can't find it, it causes a lot of anxiety. And sometimes that might be the situation. She comes in with decreased fetal movement and maybe she doesn't have any fetal movement, and what you've got is an intrauterine fetal demise. In that case, you might listen all over the whole abdomen and finally get out the ultrasound machine and take a look and see what's going on. But the easiest, smartest way to do it is to feel for a back at least. I mean, you might not be great at Leopold's maneuvers, but you should be at least able to find the back. And if you can find a head versus a butt, that can help you decide whether the baby's vertex are breached too, and that will help you hear fetal hearts. So that's Leopold's maneuver, and I think that's basically what we typically see at a prenatal nursing appointment, aside from all the massive education that we give people, which is covered in a separate topic. So we routinely assess the well-being of the fetus throughout pregnancy. In addition to our fetal heart rates, we rely on mom's verbal accounts of fetal movements. And we may ask her to keep what's called a kick count, which is a record of fetal movements. That's sort of a low-tech thing that we do. And there's other testing that we do. It's become routine to do ultrasound. A lot of people get several ultrasounds, even low-risk patients. Typically, you'll see at least one anatomy scan at about 20 weeks, but you may see an early ultrasound, especially if you need to confirm a pregnancy or to date the pregnancy. If mom's LMP is not a reliable indicator, if she has irregular periods or something like that, you might see an early ultrasound. And they used to almost always do those as a transvaginal, but now the equipment's a little bit better. Sometimes you can do them as a transabdominal ultrasound. So those are two pretty routine assessments of fetal well-being. Now, even low-risk women sometimes get screened, very often get screened for some genetic abnormalities. And we can do that in a less invasive way by using that ultrasound to measure the thickness around the neck. Of course, this is going to autocorrect to something weird. Nope, didn't do it. Nuchal translucency. And we see that particularly with the trisomies, 21, 13, 18, because these babies lay down some extra collagen in that area. So we measure that, and if it's increased, we have a suspicion, a high index of suspicion for a trisomy. Sometimes that nuchal translucency is combined with maternal serum AFP or alpha fetoprotein, which is a protein that gets in mom's blood. So combining those two markers gives you a pretty good indication of what you might want to screen a little bit more. You do get false positives with this, but this is done usually in the first trimester, but at about weeks 10 through 12, a nuchal translucency combined with the maternal, the MSAFP. If the AFP is low, it's a it's a marker for Downs, okay? And the nuchal translucency is another marker for Downs. So those two things together a lot of times will lead people to seek further testing. Now, since we're on the subject of that, there are some new maternal serum testing, and we're using it pretty extensively at Capital Health for women who are at risk. Maternity 21 is one like sort of brand name, and this detects very small fragments of fetal DNA circulating in the mother's serum. And then we have another one, the brand name is called NIPS. It's the same basic test, it's just different companies that offer it. They don't screen for every disorder, but you can find the XY chromosome, the sex-linked pair sometimes. It's not always conclusive for that, but if you have a trisomy, very often you will find pieces of that trisomy. You'll find, a little sampling of that. So those are things that can be offered to people that are not invasive. The fetal movement and the ultrasound are almost, they're routinely offered to every fetal movement. Always we check. Ultrasound, I think most women get ultrasounds during their pregnancy, and the first trimester screen is also offered early. People also get the quad screen later in pregnancy. These are serum tests. And a test for 4 markers. Basically, one of those markers is that alpha-fetoprotein. When you have elevated alpha-fetoprotein, you're looking at possible neural tube defects like spina bifida, because you have cerebrospinal fluid leaking into, into the circulation. And that does sort of reach that the alpha-fetoprotein reaches the maternal serum, and you can measure that. If you have Down syndrome, you have a reduced alpha-fetoprotein. So that is sort of how that works, and I'm just going to make a note so that you understand the significance of that. So if you have, sorry, I don't have an arrow up sign, but increased AFP, you look at neural tube. Neural tube defects, open ones in particular. Okay, if you have decreased, it's a marker for Downs. It is not diagnostic for either one of these things. So you would just indicate the need for further testing. And this is usually offered, hold on, the quad screen is usually offered at about 16 to 18 weeks. And again, it's offered routinely even to low-risk women because it's a not an invasive test. Obviously, if people are thinking about making decisions about pregnancy, they're going to be a little bit more inclined to look at the first trimester screen and the maternity 21 and the NIPS, where you can do that screening earlier in pregnancy, to wait until 16 to 18 weeks. When we talked about the maternal tasks of adaptation to pregnancy, at that point, moms are, sort of accomplishing those tasks of binding in and ensuring safe passage. And so this can be a very difficult decision if they're presented with the choices. And generally speaking, most patients will want earlier screening that's a little more definitive if it's offered to them. Okay, and so while we're talking about tests for genetic disorders and things like that, we can revisit tests like CVS, which is the chorionic villus sampling. Okay, and that is, if you remember our little discussion of how the placenta develops, the chorionic villi are those little projections that come from fetal tissue, that trophoblastic tissue, and kind of bury themselves into the uterine lining. We sample from there, and you can see the karyotype of the individual, of the fetus. So you get a pretty complete picture. And that can be done fairly early in pregnancy, say as early as about 9 to 11 weeks. There is a risk about less than, it depends on where you have it done. If you do it at a center that does a lot of CVS, your risk is less than 1%. It's approximately, we'll just say 1% miscarriage risk. Okay? And that's chorionic villus sampling. It's a little bit trickier to do than the next test that we're going to talk about, which is amniocentesis, which is a sampling of the amniotic fluid. And they just put a 22 gauge needle. It's long, but they go through the uterus guided by ultrasound to sample the amniotic fluid. Okay, so that's amniocentesis. And they get the same type of cell as the fetus sheds cells. They can sample the DNA of those cells and look for a karyotype. So amniocentesis can be performed after 15 weeks when the volume of the fluid is adequate. Okay? Now, we sample amniotic fluid for that karyotype, but we also sample it for other things. We might use it to determine what we call the LS ratio, which is the lecithin sphingomyelin ratio. Now, what does that do? What does that really mean? This is a marker for fetal lung maturity. When the fetal lungs are mature, the ratio of lecithin to sphingomyelin will be 2 to 1. If it's less than that, your lungs are immature. So if you're making a decision about delivery, let's say mom has diabetes, and you're worried because the baby's getting bigger, and you're not sure, placenta seems to be functioning okay, but you think that maybe this baby needs to come out. Baby's 37, 38 weeks. Now, diabetic lungs mature slower than non-diabetic lungs, and there are good pathophysiological reasons for that would make this video a lot longer, and I'm not going to get into them. But just know that when you're deciding whether or not to induce as a medical induction, this might be a test that you do to determine fetal lung maturity. So if your LS is less than 2 to 1, you should ideally wait. Okay, so that's the LS ratio. It's another thing we use amniotic fluid for. Okay, let me make that a little bit smaller. We can keep going and put some more stuff on here. Not to clutter it up, but we're sort of working in the same ballpark here. The other things that amniotic fluid can be used for, you can see some inborn errors of metabolism. And it's not commonly used for that. It's commonly used for karyotyping in the LS ratio, but you can also see sometimes an increased protein in that fluid, which might mean a neural tube defect. Okay, but the most common, and I'm going to sort of repeat that, I'll just even erase these. So you know the amniotic fluid can be tested for a lot of different things, okay? But the two most common things that it's tested for are for the sampling of genetic material and for the LS ratio. And again, remember that the LS ratio at 2 to 1 means lungs are mature. If it's less than that, they are not mature, because that tends to show up on a lot of tests too. And maybe I can make this a little bit bigger and put a little star next to it and give you some time to write it down. And it might not show up on exam 3 or exam 4 or, ATI. It could be on the final. It could be in a lot of places. So, you want to just know that that is the right, that's what that finding means. Okay? So there you go. That's your amniocentesis. Other tests that we use to determine fetal well-being, there is a non-stress test. And this uses fetal monitoring to determine whether or not the baby has an intact nervous system and a good acid-base balance. A normal non-stress test is considered reactive. We like reactive. Reactive means that the baby has a nervous system that reacts to the demands of the body. If the baby moves and kicks, the heart rate goes up just like yours does when you run or when you walk. Your heart rate goes up with activity, it returns to baseline. So we like to see what reactive looks like to us when we look at a strip. Two, accelerations of the fetal heart in a baby above 32 weeks. It gets a little bit tricky, but we're just going to go with the standard definition. If your baby is 32 weeks and their nervous system has matured, we want it to be 15 beats per minute above the baseline. So first we have to establish a baseline. And we want those accelerations to last at least 15 seconds. Okay, so we twice on this strip in 20 minutes. In a 20-minute period, you should have 2 accelerations of the fetal heart rate that go 15 beats above the baseline for at least 15 seconds in 20 minutes. And I'm going to find a picture somewhere of what that strip might look like. And there it is. Okay, so I'm going to make it really big and cover up a lot of other stuff just so I can show you what I'm looking at. Okay, so I'm looking at a baseline, and you always look for between contractions. Lady's not really contracting. She has a little bit of irritability, and her uterine monitor is down here. So I'm going to say that her baseline, well, the way I'm reading it, is at 150, okay? And you only give it one number. We'll discuss fetal monitoring as a separate concept, but it has to go to be reactive up to at least 165 and stay elevated for 15 seconds. It doesn't have to be 165 for 15 seconds. It's just that the entire accel from, say, here to here has to be at least 15 seconds. Each one of these squares is 10 seconds long. So let's take a look. Does this change in the baseline meet the criteria for reactivity? Yep, she's at this point 145, 150. I'm going to call it 145, so I only really need it to go up to 160, okay, just at this point in the strip. It goes up to 180, which is pretty good, and stays, that accel lasts about 40 seconds. So that one definitely meets the criteria. Okay, so I'm going to look at this one. Does this one meet the criteria? Okay. At this point, the baseline's 150. So we need it to go up to 165. Again, it goes up to 180. Okay. And it lasts about, there's a half a block, a whole block, a half a block, about 20 seconds. So that meets the criteria. So this is a reactive strip. If you have a non-reactive strip, hold on. Non-reactive means that it doesn't meet the criteria. It does not have 2 accelerations of the fetal heart rate, 15 by 15. And a reactive strip is considered a reassuring sign. It's associated with an intact nervous system and a normal acid-base balance. Non-reactive, you leave them on the monitor for about 40 minutes before you call it non-reactive. Usually, that means that they don't have any accels that meet that criteria. They don't have 2 accels that meet that criteria within 20-minute period. If you leave them on for 40 minutes or even leave them on for an hour and they still don't get those 2 that are close together, usually if we get a non-reactive strip like that, baby's not jumping up and down and showing us that he reacts. A biophysical profile, otherwise known as BPP. Some docs will order these on your high-risk patients, like your diabetics will get a BP ultrasound with a BPP once in the, third trimester, and then as needed, if decreased fetal movement or if a non-reactive non-stress test. Okay, so a BPP, biophysical profile, measures 5 criteria. You either get 2 points or you get 0. It's an all or nothing. Okay, so that is what a BPP. Let's move that out of the way. Okay, so if you have a BPP, the first thing we look at is a reactive non-stress test. That gets you 2 points. If it's not reactive, you already have 0 points. So let's say you're being referred for BPP for a non-reactive stress test. You already lost your 2 points. Okay, and then we look at movement. And by fetal movements, we want to see at least 3 or more limb or trunk movements. And these aren't just little tiny, like, floating around. This is like a kick or a flexion of that arm muscle. So we want to see at least 3 body okay, and that gets you a 2 or a 0. So if this baby is sort of sleepy and not moving, now you lose another 2 points. You don't want to lose a lot of points on these because you end up usually delivering. And if you're not term and you're not ready, that's not a good thing. So fetal tone is the next parameter that we measure. And we want 1 or more instances of full extension and flexion. Of a limb or trunk. Okay? And that's fetal tone. 2 points or no points. Now most babies will score for that one. And most of them will get the movement, some of them won't. 4 is fetal breathing. And this is practice breathing. Remember, what the baby's inhaling and exhaling is amniotic fluid. And so they don't need a lot of breathing. They don't need repeated breathing movements. They don't need a lot to score here. But what they need is 1 or more. These are practice breaths. More than 30 seconds. And this is all done via ultrasonography. Okay, and then there's amniotic fluid volume. And what they do is they look for 1 or more pockets. On the ultrasound, it's going to look like black. Fluid always looks black, and then solid tissue is some variation on gray. 1 or more pockets measuring 2 centimeters scores you a 2. If you don't have 1 or more pockets that measure 2 centimeters, you get a 0. Now, generally, people will fail. If you have a score of 8 out of 10, they're usually okay with it. If you have a score of 6 out of 10, they're probably going to rescan you at some point and watch you on the fetal monitor to make sure that the baby's okay. If you have a score of 4 or below, you're usually recommended for delivery. But that's a biophysical profile, and it is a measure of fetal well-being. So that's that. A contraction stress test is very rarely performed anymore, and what it does is it predicts how well the fetus is going to tolerate labor. It has to be done on labor and delivery, and to tell you the truth, I have not seen a contraction stress test in a long time. What they do is they hook the mom up to PIT, put her on the monitor, and they see how the baby reacts, how the fetal heart reacts to contractions. They look for late decelerations, they look for minimal variability, but they look for signs that maybe this baby won't tolerate labor. You have to do it on labor and delivery because you could really put the person into an induced labor. So it's done where you suspect that the placenta is not very good. Honestly, most of the time, if they're really that concerned, they're just going to bring you in for induction. And it is a contraction stress test because they'll call it an induction. But when the baby shows signs that it's not tolerating labor, they stop the induction and they deliver via C-section. So that's a contraction stress test, and you probably will not see it as such. Okay, and so one more test that you might see reference to in your books, you probably won't see it unless you work in a high-risk perinatal center, is something called percutaneous umbilical blood sampling. I just can't type anymore. Or PUBS for short. I got to see one once. A mom came in and she had apparently never been given RhoGAM after one of her pregnancies. She was discharged. It was a mistake. It was a medical error. Discharged from the hospital without having received her RhoGAM. She was told she was not a candidate because the baby's blood type was compatible with hers. However, it wasn't, and she had developed antibodies, and now this fetus was developing signs of something called hydrops, which is what happens when the mom's antibodies sort of attack. So they had to do a PUBS sampling, and they do this guided by ultrasound, and they insert a needle into the umbilical arteries to get fetal blood sampling. Now the problem with it is A, it's very tricky and hard to do. And B, you can cause laceration to the cord, you can cause leakage of blood into the amniotic fluid, and you can cause, clot within the cord, preterm labor, infection. It's just not a low-risk procedure. So it's not done without cause. Usually if it is done, it's done at a tertiary care center. So that's PUBS. It's something you'll see in a book. It's probably not something you'll see in practice.